Hello, and welcome to the ProCE Oncology podcast. I'm your host, Marie Becker. Today's episode features Allison Butts, PharmD, BCOP from the Markey Cancer Center in Lexington, Kentucky, and Danielle Roman, PharmD, BCOP from Allegheny Health Network in Pittsburgh, Pennsylvania. They will be discussing the use of antibody-drug conjugates, or ADCs, in solid tumors with a focus on adverse event management. This episode is part of a larger educational program titled Precision Payload, ADCs for Solid Tumors and the Essential Role of Oncology Pharmacists in TRAE Identification and Management. For more information on our presenters, along with a link to the full educational program, please visit the show notes for this episode. Now let's get started with Dr. Butts and hear what our faculty have to say.
It's a pleasure to be with you. I'm going to get started with a high-level overview of the drugs that we'll be discussing today, and then Danielle will cover toxicity management in more detail. There's a couple of really important components that make up ADCs, or antibody-drug conjugates, starting with the antibody backbone itself. The antibodies used for ADCs are generally chimeric or humanized monoclonal IgG antibodies that are used to target something that is specifically expressed on the tumor surface. We'll talk today mostly about HER2, TROP-2, and HER3, but this could be any number of targets. The second piece is the linker. The linker is there to connect the payload to the antibody, but what's important to note is we have cleavable linkers, whether that's something like a disulfide bond that's broken or something that's hydrolyzed within the tumor cell, or we could have non-cleavable linkers where the entire molecule, the whole antibody drug conjugate, gets internalized to a lysosome, broken down, and then released from there. So two different main classes of linkers. Finally, we have the payload, which is typically a very toxic chemotherapeutic agent. There's a number of factors within the payload that are important to consider, such as the drug to antibody ratio, which is simply how many of these toxins are tethered to an individual antibody, the lipophilicity, which impacts the ability of the drug to permeate into neighboring cells, and then the half-life, which of course could affect our toxicity and efficacy of the drug. There's multiple different payloads that are being studied or on the market today. Looking more at the mechanism of action, the antibody drug conjugate binds to the target receptor on the cell surface, forming the ADC antigen complex. After this binding happens, this complex is internalized and targeted for destruction within the tumor cell itself. The ADC is processed within endosomes or lysosomes, which releases that payload so that it could have that cytotoxic effect on the target cell of interest. Increasingly important, though, is this concept of the bystander effect. Once the toxin is released from its antibody, it's able to migrate into neighboring cells. That could be a tumor cell that maybe isn't highly expressing that surface receptor, or it could be a normal healthy cell. Either way, this could have benefits and potential risks as well. Finally, the antibody component of the ADC in some cases will engage with immune effector cells to trigger additional destruction via the ADCC mechanism. There's a couple of mechanisms of toxicity that we want to be aware of, starting first with the expression of the target protein on non-cancer cells. So certainly the mechanism of the ADC relies on this target being expressed on the tumor cell, but as we know, some of these targets are also on healthy cells. So thinking about HER2 being expressed on the endothelium throughout the body. So the trastuzumab antibody drug conjugates are not only hitting the tumor cells, they're also potentially targeting the epithelium that's expressing HER2. The location and mechanism of the linker cleaving is something else to be aware of. So we want to make sure as much as possible that that linker is cleaved within the tumor cell, but there could be some leakage to where the toxin is being released either outside of the tumor cell or a potential for migration of that toxin into neighboring cells if that toxin is membrane permeable or lipophilic. So if we are having this leakage of the toxin into the bloodstream or into neighboring cell areas, we could be damaging healthy cells in addition to the target. Now we'll move into some of the currently approved drugs, starting with our anti-HER2 therapies. Many of you are probably familiar with HER2 being a transmembrane receptor. It functions by dimerizing with another member of the EGFR or ERB family, which could be HER1 through 4. After dimerization, there's downstream signaling through a few different pathways that ultimately leads to survival, proliferation, and angiogenesis within the tumor cell. anti-HER2 therapies have potential for use in a number of different cancers, starting with breast cancer, gastric cancer, and then a number of others as well. Lining of the GI tract, the skin, the cardiac myocytes all express HER2 also, and that's where some of the toxicities that Danielle will speak about come into play. Trastuzumab emtansine was our first ADC in the HER2 space. It is the same trastuzumab backbone that we're well familiar with. Linked to it via a non-cleavable linker is a very potent mitansine derivative and antimicrotubule payload that is tethered to that antibody. The drug to antibody ratio is on the lower end, about 4 toxins per antibody. The FDA-approved indications currently are both in the breast cancer space and metastatic breast cancer. Trastuzumab emtansine is approved on the basis of progression-free survival and overall survival for patients who were previously treated with trastuzumab and a taxane. About 6 years later, it was approved in the adjuvant space, again on the basis of impressive disease-free survival and overall survival. Specifically, the drug is approved for patients who have received neoadjuvant treatment and have residual disease after completion of that neoadjuvant therapy. And that's where it's been shown to significantly reduce the risk of recurrence and therefore survival. Moving into trastuzumab deruxtecan, this agent is that same trastuzumab backbone. This time, trastuzumab deruxtecan has a much higher drug to antibody ratio of about 8 molecules of toxin to 1 antibody. And that payload specifically is a topoisomerase 1 inhibitor. The linker on this drug is cleavable, which allows for the bystander effect in combination with the fact that the toxin is membrane permeable. So this is a very potent drug, and as such, it has been approved in many different areas. Looking at the breast cancer indications briefly, we know that this drug is approved in metastatic breast cancer that's HER2 positive. That was its first approval. It's actually moved up in the treatment algorithm to the second line setting, and that again is based on our PFS and overall survival benefits in the HER2 positive space. The next indication was in HER2 low tumors. So these are tumors that basically did not quite meet the criteria for HER2 positivity. HER2 low definition is those who are IHC 1+ or 2+ but had a negative FISH ratio. So in the DESTINY-Breast04 trial, trastuzumab deruxtecan showed to be very positive for patients with HER2 low disease. Last but not least, our more recent indication for breast cancer came from the DESTINY-Breast06 trial that looked at patients who are either HER2 low, as previously defined, or HER2 ultra low. So HER2 ultra low is those with IHC 0, but they do have some amount of membrane staining. So this is very minimal amounts of HER2 expression, but the drug seems to still be efficacious in that population. I will add for that HER2 low and HER2 ultra low that patients have to be HR positive or hormone receptor positive as well to qualify on the basis of that study. Moving into our gastric and GE junction carcinoma, the DESTINY-Gastric01 trial found trastuzumab deruxtecan to be beneficial versus physician's choice chemotherapy. PFS was improved and overall survival also improved there as well. So that is an indication in the gastric and GI junction space after trastuzumab therapy. Non-small cell lung cancer is a little bit unique in that there's an additional qualifier for HER2 positivity that comes into play here. Specifically, about 2 to 4% of patients with non-small cell lung cancer have a HER2 gene mutation that can be detected on next-gen sequencing, specifically in exon 20. So where trastuzumab deruxtecan has its indication for non-small cell lung cancer is specifically in those patients with a gene mutation, as was studied in the DESTINY-Lung02 study. PFS was pretty impressive at about 10 months, which led to accelerated approval of trastuzumab deruxtecan for non-small cell lung cancer. Even more recent, trastuzumab deruxtecan now has an indication for unresectable metastatic HER2 positive solid tumors across the board. Data from a couple of different studies that led to this approval, the PanTumor02 trial especially included patients with a number of different tumor types, and then we could add the lung data as well as colorectal data into that, and this led to an accelerated approval across the board for HER2 positive solid tumors who previously received systemic treatment and have no satisfactory alternative treatment option available. Moving on, we'll now look at our anti-TROP-2 agents. TROP-2, for a quick overview, is an epithelial adhesion molecule that regulates many different pieces of the cell cycle or the cell lifespan, including regeneration, growth, and transformation. It is overexpressed on many different tumor types. We will specifically talk about breast, since that's where the drug has its indication currently, but you could see potential opportunities in multiple different tumor types as TROP-2 is highly expressed in several different cancers. Sacituzumab is a anti-TROP-2 humanized antibody. It has a similar profile to trastuzumab deruxtecan, I would say, in that the drug to antibody ratio is about 8:1. This time we have a pH-sensitive cleavable linker that aids in release of that toxin within the tumor. The payload is SN38, which you might recognize as the active metabolite of irinotecan in metastatic triple-negative breast cancer. This is where sacituzumab got its first approval via the ASCENT trial. We saw an improvement in progression-free survival as well as overall survival, and it now has a full FDA approval for patients with metastatic triple-negative breast cancer after 2 or more lines of prior therapy, one of those being in the metastatic setting. It later got approved in the hormone receptor-positive breast cancer space, again with metastatic disease who were previously treated. And this has not quite as numerically impressive results as what we see in the triple-negative population, but alas, we do have a full FDA approval for sacituzumab in the HR-positive metastatic space also for breast cancer. More recently, we have Datopotamab deruxtecan, which is a newer anti-TROP-2 drug. We now have a tumor-selective cleavable linker, again, a tetrapeptide-based linker, and its payload is a topoisomerase inhibitor, again, same one that we've seen with trastuzumab deruxtecan. The bystander effect is very important with this agent also. DXd is approved based on TROPION-Breast01, which studied patients with HR-positive metastatic breast cancer. And what the results show is an improvement in overall response rate, an improvement in progression-free survival, and thus we have an FDA approval for Dato-DXd. There's also some investigation ongoing for non-small cell lung cancer. And with that, I will turn it over to Danielle to take over on AE identification and management.
Thanks, Allison. We're going to move on to talking about side effect profiles, how to identify side effects, and also from the management end, kind of how are we going to prevent these as well as manage them if they do occur. We're going to start with a discussion of the adverse effects associated with the ADCs that target HER2. So first, a brief discussion of T-DM1. This is the agent we've had on the market for the longest period of time now, so do have pretty significant experience in managing these side effects. So overall, I would say generally a well-tolerated agent, but a couple of toxicities to note, certainly with the fatigue, hepatotoxicity, some myelosuppression, particularly with thrombocytopenia and neuropathy are things to watch for. Switching gears here as we talk about trastuzumab deruxtecan or TDXD. Alopecia is something to note with this agent that somewhere between 20 to about 50% of patients will experience at least some thinning of the hair. And then certainly something of note here is interstitial lung disease or pneumonitis, listed at 9 to 12% of patients. You again see a low risk of left ventricular ejection fraction decrease. There's also a risk of hepatotoxicity with increased AST and ALT. Nausea rates are fairly high, which we will discuss in a little bit more detail as well. And then we do see some, with the cytotoxic component, we do see some neutropenia as well as thrombocytopenia. And again, fatigue is something that we're monitoring very closely. So in terms of those black box warnings with trastuzumab deruxtecan, ILD and pneumonitis, as well as embryo-fetal toxicity. So as we move on to specifically some discussion of ILD, this is something that we see with other agents. So we can see it with cytotoxic chemotherapy with our taxanes and anthracyclines. We can also see this with targeted therapies, other targets against the anti-HER2. We see this with some of our oral targeted therapies, such as our CDK4/6 inhibitors, osimertinib, everolimus. So a number of agents that we're using in oncology can have this toxicity, although it is certainly one of interest as we talk about trastuzumab deruxtecan. Interstitial lung disease, the interstitium is the space between the alveoli of the lung and the capillaries where oxygen taken to other parts of the body and distributed to organs. We need to have effective exchange of oxygen between the alveoli and the capillaries. Interstitial lung disease is damage to that interstitium, so disruption of alveolar structures and fibrosis that limits that gas exchange. The mechanism here is not well elucidated. As a high-level summary, with sacituzumab govitecan, really very limited to no risk of ILD. If we look at TDM1 and Datopotamab deruxtecan, fairly limited risk. But particularly when we look at TDXD, this is where we see the highest risk. So up to about 15% seen in some of the breast cancer trials. And I think what is particularly noticeable is that there was some cases of grade 5 or fatal ILD that were seen in many of these clinical trials. And this was despite understanding that the risk was there and really intense monitoring that was happening in these trials. Fatality rates decreased, but we still continue to see some fatalities on these trials. So certainly a side effect that is very notable with TDXD and one that we need to monitor for very closely. There was an interesting pooled analysis that was done of 9 phase 1 and 2 trials of TDXD in solid tumors. What they found in this pooled analysis is that the overall incidence of ILD was about 15%, so significant risk. However, most were grade 1, 2, and most of the events occurred within the first year of therapy. So certainly the risk does carry beyond a year, but really recommending really intense monitoring in that first year to pick up these cases, hopefully early as a low-grade event. Another important point that came out of this pooled analysis was looking at subgroup analysis, hoping to identify risk factors that would help us understand the patients that carry the highest risk. What they found here was that these potential risk factors included patients that were younger age, so less than 65, those treated in Japan, those patients with lung comorbidities at baseline, those patients with some degree of renal dysfunction, so moderate to severe renal dysfunction, as determined by the Cockcroft-Gault formula, for those patients that were more than 4 years out from their diagnosis, those with a higher dose, so greater than 6.4 milligram per kilogram dose, which of note is doses that we're using more in the gastric space, and as well as those patients with low baseline oxygen levels. So these were risk factors that can potentially identify higher risk patients. We don't necessarily have any specific differentiation in terms of screening strategies, but for patients that have these baseline risk factors or potentially multiple baseline risk factors here, you may want to consider more frequent monitoring and certainly intense patient and caregiver education for people taking care of these patients. We're next going to talk about our treatment algorithm once we have a patient with ILD. So certainly early identification being very, very important. So this should be part of our regular patient and caregiver education as we start patients on TDXD. They should be counseled to immediately report any changes in their breathing. So new onset cough, dyspnea, fever, really any new or worsening respiratory symptoms. Based on this, we should do an assessment. So high resolution CT is the preferred test to confirm a diagnosis of ILD. Rule out any other potential causes of respiratory change before moving on here. So potentially involving our pulmonary colleagues, as well as our infectious disease colleagues here to help just confirm the case of ILD. For patients with asymptomatic disease, this is considered to be grade 1 ILD. And the recommendation is to hold until patients have resolved to a grade 0 or no evidence of ILD. There's also a consideration for corticosteroid treatment here. This is usually a 0.5 milligram per kilo prednisone dose or potentially up to 1 milligram per kilo here. For patients that are symptomatic, they are diagnosed with a grade 2 or greater disease or symptom here. And the recommendation is to permanently discontinue the drug. these patients should initiate systemic corticosteroid treatment with 1 milligram per kilogram of prednisone or equivalent for at least 2 weeks of treatment, followed by a taper for at least 4 weeks. Again, for those symptomatic patients, we are not going to re-challenge. For those patients with grade 1 or asymptomatic disease that is caught oftentimes on routine monitoring, these patients can resume therapy once we have resolution. If that resolution has occurred at 28 days or less from the onset of ILD, we can restart with the same dose. But for those patients that it takes longer, so greater than 28 days from onset to resolution, the recommendation is to dose reduce here. And once the drug is dose reduced, it is not recommended to re-escalate. Once patients get to that third dose reduction, it is recommended to permanently discontinue the agent. I'd like to also just mention there isn't a specific recommendation in terms of our monitoring outside of we know we want to do a high resolution CT scan as a monitoring strategy, and that is anywhere from every 6 to every 12 weeks. So currently in my practice, we are checking high resolution CTs every 9 weeks, which is around the time that we're checking for disease response to therapy. A brief overview of 5S rules for detecting and managing T-DXd-related ILD screening. So we discussed a very important component of treatment, so careful patient selection and making sure that those patients are getting those high-resolution CT scans every 6 to 12 weeks throughout therapy. Scan here being the second S we discussed. Synergy, so a team approach to identifying and managing these side effects. This is the patient and caregiver team. This is the oncology care team, including our nurses that are working very closely with these patients in the infusion centers, our clinic teams, as well as often pulmonary and ID support. Our fourth S, suspending treatment, so stopping the drug immediately if ILD is suspected, and only resuming if a patient has grade 1 disease that has completely resolved. And then finally, our fifth S here, steroids, remembering that this is an important component. It is a consideration for grade 1 disease. It is often used in my experience in that setting, but certainly a necessary component for any patient that has symptomatic ILD. Another important consideration with T-DXd is the significant nausea and vomiting risk. This agent is categorized as highly emetogenic by NCCN guidelines, and it is recommended that we premedicate with a 3 to 4 drug regimen here to prevent chemo-induced nausea and vomiting. So this is generally a steroid, a 5-HT3 receptor antagonist, an NK1 receptor antagonist, plus or minus olanzapine. And an important note that the side effect may be delayed, so we want to make sure that we are covering patients not just on that day 1 of treatment, but also for about the first 4 days after treatment with prophylactic antiemetics, and making sure that they have a take-home antiemetic to use as needed beyond that. Another important adverse effect with T-DXd is neutropenia. So this is likely an adverse effect that many of you are familiar with managing in many other anti-cancer therapies. But here, educating patients on the potential for neutropenia, it is important to note that this is usually a low grade, low risk of febrile neutropenia here. We do want to monitor a CBC with differential before starting treatment, before each dose. So this is every 3 weeks and is clinically indicated. The median onset for neutropenia is usually somewhere in the 2 to 3 day range after starting treatment. It is recommended to hold the drug if the patient's ANC is less than 1,000 or if they have neutropenic fever. Dose reductions are warranted for a patient with grade 4 neutropenia or those patients with grade 3 febrile neutropenia. Discontinuation of the drug should be considered for patients if they have required multiple dose reductions. So if you get to your 3rd dose reduction, discontinuation is recommended. G-CSF could be a consideration for here for patients that do present with neutropenia, so potentially doing this as secondary prophylaxis, and for patients that have a significant history of prior neutropenic complications. Left ventricular dysfunction is something that we are familiar with monitoring with other HER2 targeted therapies. and it has been reported at about 2 to 8% in clinical trials with this agent. But we do want to monitor LVEF prior to initiation of T-DXd. This is either with an echo or a MUGA scan, and at regular intervals throughout treatment. This is not well delineated in the prescribing information of the drug. In my clinical practice, we, at least as we initiate the drug, do this every 3 months, but occasionally space this out as patients are stable on this drug for long periods of time. The recommendations for management here are based on that absolute LVEF that's determined on the echo or MUGA scan, as well as comparing to previous echo or MUGA scans to look at the absolute decrease from baseline. It's important that if you start with a MUGA, ideally you continue with that versus starting with echo, continue with an echo so that you're comparing apples to apples here. If we have a patient with an LVEF of 40 to 45% and an absolute decrease from baseline of 10 to 20%, this is a patient where it's recommended to hold the drug and to reassess the LVEF within 3 weeks. If the patient has not recovered at baseline, it would be recommended to discontinue. If recovered within 10% from baseline, you can resume. And then for patients that either have an LVEF of less than 40% or an absolute decrease of baseline from greater than 20%, the recommendation is to hold it, reassess within 3 weeks. If this is confirmed again, it would be recommended to discontinue the agent. And then for a patient with a diagnosis of CHF, it is recommended to discontinue T-DXd. Okay, we're now going to move on to considerations for adverse effects with our TROP-2 targeted ADCs. Just a few notable things here with sacituzumab govitecan: a significant risk of fatigue, fairly significant risk of hypersensitivity reactions that we will briefly mention. Alopecia is a concern in up to 50% of patients. Significant risk of nausea and vomiting, and over half of patients experiencing that. Diarrhea risks that are very high. A significant risk of neutropenia as well at 64%. A brief overview of the Dato-DXd. Again, alopecia is an adverse effect in up to 40% of patients. So Dato-DXd, we see a risk of ocular events and stomatitis, low risk of ILD. Nausea is something of concern here. Again, fatigue is something that is notable with this agent, and then a low risk of hypersensitivity reactions. SG does carry the black box warnings for neutropenia and diarrhea. The prescribing information for sacituzumab govitecan does mention UGT1A1 testing. So UGT1A1 is an enzyme that breaks down that SN38 payload of this agent, and genetic polymorphisms in this can result in reduced activity and therefore increased toxicity with this agent. So in particular, patients that are star28 diplotypes can have poor metabolism of the agent. So early identification may be helpful to identify those patients that may be at greater risk for toxicity, may need early dose reductions. So this potentially could be baseline as patients start the agent, but certainly for patients that are presenting with excessive toxicity, it may be worth checking for this particular genetic polymorphism. We mentioned diarrhea, an AE of interest here, and important to first consider grading. So we're looking at our stools over baseline. For patients with grade 1 or 2, so this would be less than or equal to 6 stools over baseline, we need to first consider the time frame for which the diarrhea is occurring. So for patients with an onset that is during or shortly after their infusion, this is generally considered an early or acute diarrhea that is associated with a cholinergic syndrome. So think of irinotecan here. So this is very similar to what is occurring with SG. You don't necessarily need to use atropine as a primary prophylaxis here, but it should be the drug that we're reaching for in patients that experience this adverse effect. If patients have this, prophylaxis with atropine during future infusions would be recommended, and we can continue SG at the same dose. For those patients with delayed onset, you're going to think of, again, typically what we would do for irinotecan in this setting, where loperamide is our agent of choice, as well as dietary management. For patients that don't have resolution, you can escalate this to high dose loperamide, 4 milligrams at time of first loose stool, and then 2 milligrams every 2 hours around the clock. You can also include, if that does not resolve things, you can look at other things like octreotide for refractory diarrhea. And certainly important to also still be considering infectious causes of diarrhea here. For those patients that have greater than or equal to 7 stools over baseline, so a grade 3 or grade 4, these are patients that are going to need to be more aggressive, so potentially considering hospital admission, octreotide, considering antibiotic therapy as well as here, and then potential considerations for dose reductions once you have patients who don't recover quickly or have grade 4 diarrhea. We mentioned another toxicity of interest with SG is neutropenia. This can potentially be severe. Again, onset here is about 2 to 3 weeks after treatment, median duration of 6 days. It's important to check a CBC with differential before dosing each treatment. So this would be on days 1 and 8 of each cycle. For patients that have an ANC of less than 1,500 on day 1 or less than 1,000 on day 8, or those patients that present with neutropenic fever, we should be holding drug. Management with G-CSF is important. Considerations for anti-infective therapy for patients that have febrile neutropenia. And the dose reductions here are really dependent on how long it takes for the patient's counts to recover. So if the patient has delayed recovery by about 2 to 3 weeks, then dose reduction would be warranted. Additional toxicities, we're not going to cover those in great detail, but risk of hypersensitivity reactions, so pre-medication is very important. Prolonged first infusion here at 3 hours, and close observation of patients. Nausea and vomiting, it is a high risk here, so a 3 to 4 drug regimen, as we previously discussed for T-DXd, is also appropriate for this agent. From a prevention standpoint, you have a risk of mucositis with deruxtecan. So advising the patient on steroid-containing mouthwash 4 times a day. They should swish for 1 to 2 minutes and then spit. Another important here is cryotherapy. So holding ice chips or ice water in the patient's mouth during the infusion to try to limit blood flow to the mucosa. Management would include continuing the steroid mouthwashes. If patients are not using that 4 times a day in the prevention setting, they should be doing that in the management setting and may need pain management strategies. And then finally, our ocular toxicity management. Ophthalmologic exam is recommended at baseline and annually on treatment. Patients should also be using a preservative-free lubricant eye drop at least 4 times a day and as needed. Median onset is usually within about 2 months. It often is dry eye, but can be a number of other ocular complications. It is recommended that patients avoid contact lenses. There's a hypersensitivity risk with this agent, so pre-medication is necessary. Nausea and vomiting risk is also high here. So I would actually recommend a 3 to 4 drug regimen. This is now NCCN high emetic risk category. And then a low risk of ILD. And that really mirrors what we've talked about already with T-DXd in terms of management strategies. A number of takeaways here. The ADC class certainly has a growing role in the management of a number of different solid tumors. Most ADCs have unique side effect concerns, many that we have talked through today. A number of ADCs are currently under development, so we will likely see more indications for these in the coming months to years.
Thank you, Dr. Butts and Dr. Roman, for a great discussion and for sharing your expertise with us. And many thanks to you, our listeners, for joining us today. As a reminder, to view the full program, Precision Payload, ADCs for Solid Tumors, and the Essential Role of Oncology Pharmacists in TRAE Identification and Management, please click on the link in the show notes. Be sure to check back soon for an in-depth look at these new therapies in an upcoming text module with downloadable slides. As always, thanks for listening.